Hello and welcome to Every Possible Angle. I'm excited to be joined today by my colleague, Mary Jacoski, our Senior Director of Medical and Scientific Affairs. And we are very lucky to have with us today Dr. Amy Fiedler from the University of California, San Francisco. She is a CT transplant surgeon, an associate professor of surgery, as well as the medical director of quality and safety. And she is the co-director of the CTICU. Dr. Fiedler, thank you for joining us.
Thanks, guys. It's great to be here.
I'd like to start by just asking you a little bit about your background and what got you into transplant surgery. What was the initial nidus that started you on this path?
Thanks, Michael. That's a great question. I think everyone has their own personal route to how they get to transplant surgery. I think mine was actually a little bit different. So I never even imagined that I would become a cardiac surgeon. When I started my general surgery residency, I was pretty dedicated to a career either in surgical oncology or pediatric surgery. I spent a lot of time as a resident, just part of our rotations in the cardiac surgery ICU. And I will never forget my second year as a general surgery resident. It was my birthday, of course, and I was doing a 24-hour shift in the cardiac surgery ICU. And that day, there was a heart transplant that had been booked with the donor recovery scheduled in North Carolina. And I was at MGH in Boston at the time, and it's a very busy service. And I'm the junior resident in the ICU. And they said, "Hey, Amy, there's no fellow available to go with the attending on the organ recovery. Would you be able to go because you're working for 24 hours anyways?" And I said, "Sure, that sounds pretty cool. I've never done that before." And I had already had I'd been gaining an interest in cardiac surgery, but I wasn't quite ready to commit myself to it yet. And I got on the plane with Dr. Jen Walker, who was a cardiac surgeon at the time at MGH. We flew together to North Carolina, and I'll never forget it because we spent the flight talking about my interests in cardiac surgery and really a lot about my hesitations about pursuing the field. And she really started to kind of talk me into it. Then we did the organ recovery together, and she let me do the sternotomy and help out with the organ recovery. And at that point, I was hooked. We flew the organ back to the hospital. I participated in the implant, and I woke up the next morning after my 24-hour shift, and I said, "That's it. I'm going to, number one, be a cardiac surgeon, and number two, I'm going to do heart transplantation." And so many years later, here I am.
That's amazing. So for you, it was a very specific moment. This one recovery that really drove you. And I have to say, transplant recovery is a unique area of medicine. I mean, where else do you suddenly get on a plane, fly across the country? There's both a lot of hurrying up, a lot of waiting, and then this very intense moment when a patient who has come into the ICU extremely sick. Suddenly has heart function again.
Yeah, no, it's truly incredible, right? And I tell my patients now when they come into the hospital, it's such a gift. It's the most amazing day for the patient when they're called in for the transplant. But every time I see them, once they're in the hospital, I say, "Okay, so now it's the hurry up and wait game." So transplant is a game of hurry up and wait. So we rush you into the hospital, you get admitted, and now we wait for the logistics and for everything to coordinate so that the transplant can go smoothly and perfectly for each and every patient.
And I think that's truly one of the big challenges facing the space, especially since the allocation changes and they're continuing to evolve right now. The continuous distributions being evaluated, which is excellent in terms of equity of access across the country, more national sharing, but it does present increasing logistical challenges. I know you've been at institutions that have classically gone very long distances and have aggressive policies to make sure your patients get access to hearts. Can you tell us a little bit about those challenges and how you approach them?
So again, a really great question. I agree. I think that we as a transplant community are really moving forward in terms of equity of access for organs and really thinking about the system holistically so that the patients who are the sickest have the highest access to organs and have the greatest likelihood of a long and fruitful life. That said, especially when you are practicing on the coasts of the United States, there can be geographic challenges with respect to organ recovery. I like to think about the process that there's each match, each recipient and donor match is individual, and you have to have the right, it's kind of the secret sauce. And a lot of times I think the risk lies in the recipient as compared to the donor. And I think if you use that in the back of your head, you're more willing, especially with new technology such as the Sherpa Pack, to push the historically thought about geographic time ischemic limits in order to find donors that may have previously been thought to be inaccessible to your institution with good effect.
We are seeing pretty rapid changes in that approach. I think when the first allocation changes happened, I definitely spoke to centers who became much more conservative in their approach because they didn't want to go further. That was because of the historic risks of cold ischemia time on ice. But then some who employed technologies and techniques and started to get aggressive and going much further in there and leveraging the policy as really as it was intended to improve that access. And I know that's an area that you're passionate about the changes to drive patient access. Is that somewhere? How do you see that patient access evolving in the next few years in transplant?
I think the doors are going to open up, and I think we're seeing that already. There's been a lot of important publications recently, I would say within the past year or so, many of which published out of the Paragonix Guardian Registry, indicating that the limits of cold storage can be pushed. We used to think about 4 hours being, anything over 4 hours, we're going to have a high rate of PGD, possible ECMO, poor performance of the donor organ. And that's very limiting when you think about the travel time, depending upon where you live. I mean, to give you an example, here in California, Northern California, even for us to go down to Southern California to a recovery center and bring an organ back to San Francisco, because of traffic, because of how long it takes in the air, we're looking already at about 3 hours of ischemic time, and that's within our own state. So if we're going to follow a strict 4-hour policy, our patients are not going to have access to organs that can be life-changing, life-saving. And so I think that we as a transplant community need to take the data seriously that's being published, saying that we can push those limits, 6 hours, 8 hours. The MGH group just published a case report about bringing a heart from Alaska to Boston. Now, I talked to that team and they said they had a favorable jet stream. So that's, advantageous to them. But the ischemic time was still long and the organ performed very well. And so as we accumulate these anecdotal experiences that then turn into center-specific or multi-center or retrospective studies, I think that we will, as a community, start rethinking what we think is acceptable for a cold ischemic time.
Absolutely. And I think your point about it, the coast, is absolutely a challenge, right? For UCSF, you've got 50% water. When we look at geographic circles as the current structure, you've got 50% water. You have a lot of mountains and desert around you. And then the other major metropolitan areas are known for heavy traffic and things like that, even just to access the airport. So those really are challenges. And Mary, your team has been doing a lot of the research on Guardian, looking at those increases to ischemic time. I know you worked with Dr. D'Alessandro recently, published that new paper.
Yeah, where we've really seen that they are going farther, and we're still attenuating that risk of severe PGD over time. It seems that we are kind of removing the connection, the prior link that we've known from studies back in 2018. Nicaragua and colleagues published that, where they saw 1.8-fold greater risk of severe PGD with each hour of ischemic time on ice. It seems that now when the more we're looking at the data, it's been very consistent with prior publications, the D'Alessandro publication, as well as data we've published at or presented at ISHLT, Dr. Silvestri presented, where we still see that attenuation even over the longer ischemic times.
Which always, for me, begs the question of there's sort of two factors there of cold and time. And whether or not the classic thought of ischemia is the driving factor here, or if the effects of cold injury play an outstanding role. And I think that's particularly interesting in DCD. You recently published research around the efficacy of DBD and DCD transplantation, which I think really is interesting, because DCD is usually at a metabolic nadir, and there's concerns and risk about transportation and use of these organs after recovery. But you're looking at new techniques and new data showing the efficacy of this new donor pool.
Mm-hmm. Yeah. And, DCD has frankly revolutionized heart transplantation in the United States and beyond, right? When we started thinking about using DCD donors, data showed that we could potentially increase the rates of transplant upwards of 30%. I mean, if you think about that, that's mind-boggling, right? Mm-hmm. Just by using this subset of donors, not even putting into place new technologies, innovative technologies, pushing geographic limits. I mean, this is just what could potentially be available to us. So when we look at that, I mean, that's something that we need to take seriously. And when we start to compare outcomes, at least early outcomes of brain dead versus DCD donors, I mean, those curves are the same. The outcomes are the same, if not superior, for DCD recoveries. And that really begs the question, have we, especially with the use of the Sherpa pack, just completely improved cold storage to the point where some of the factors that have been somewhat poorly understood related to an ice box have been mitigated by the use of the Sherpa pack? Is there something fundamental that is changing there, or alternatively with the use of, the Transmedics OCS device, which is completely different than what we're talking about today, but for OCS machine perfusion, I mean, we seem to be mitigating the impact of warm ischemia on these donor organs. Mm-hmm. Now, what I think actually will be very interesting as a transplant community as we move forward is to recognize, and we saw that in the New England Journal of Medicine paper, which was published regarding the outcomes of the first DCD trial in the United States. The DCD donors were younger donors, less comorbidities. The travel time was shorter. The ischemic time on the heart was shorter, at least in terms of the perfusion time. And so what we have to suss out next, I think, is most importantly is, these favorable outcomes for the DCD hearts still apply in the expanded donor criteria, which we have pushed the envelope to with the brain dead population? And that's a provocative question. And that is something that we, as a community, not just as the surgical and the advanced heart failure space, but also the OPOs need to recognize, because my colleagues and I actually recently wrote an editorial encouraging OPOs in the transplant community to consider DCD hearts in an expanded fashion and work them up, frankly, in the same way that we do for brain dead donors, so that we can feel confident when we go to recover those organs that those are acceptable organs. We run into some logistics issues with some OPOs aren't comfortable performing a left and a right heart cath on a DCD donor because the donor may not progress to death, at which point it might become a financial situation, or performing a procedure on someone potentially without benefit. But these are questions that we need to answer, because I think the more information we can have about the DCD donors, the more we can push to use them as an expanded donor pool, which can then just, again, open up the space to more and more availability of donor organs for transplant.
I completely agree with you. I think some of the earlier experiences certainly were, and you can see this in the data, were those more ideal donors. There was a very isolated donor pool that was underutilized, and so it was this very idealized donor pool, which certainly helps. And then as it's become more widespread, it's facing the same challenges of donor pool mix as what we've classically looked at with DBD donors. And I think recently at the American Transplant Congress, there's a lot of discussion about utilizing these donors, and certainly in the abdominal side, the use of ANRP as a way to access these organs and perfuse multiple organs all at once has been a big approach. But I know you've had experience also with TANRP as a modality to potentially reperfuse multiple organs all at once, and then increase access to this donor pool. Can you tell us a little bit about your experience there?
Sure. I think NRP, TA-NRP in particular is a very, very exciting addition to our armamentarium in terms of donor recovery. It's different than using an out of body machine perfusion in order to recover and assess the organ, but it works. And not only does it work for the heart and for the lungs, but it's really advantageous for the abdominal organs as well. And so I think when we consider donors, we need to consider them holistically. And when a person has made the decision to donate their organs to the good of society, to the good of the recipients, it's best if we can have the highest quality organs recovered from that individual. And TA-NRP has really revolutionized that, specifically within the DCD space. I was really lucky to be at an institution, my previous institution, also my current institution. But at the time that TA-NRP was starting to be considered in the United States, we were pretty forward thinking, and we were able to roll that out and develop a very robust TA-NRP program with good success. And I think it is an important component. It can't be the only component of your DCD transplant program, but a very, very important component in order to recover these organs successfully.
One of the things I think is certainly a challenge in transplant is the size of the teams, the complexity of the teams. Certainly, you have a very large team there, and I think there was recently some exciting news from your institution about the first all-female transplant team going out on a recovery. Can you tell us about that?
Sure. It wasn't a recovery. I think that your team recovered the heart for us, but it was the implant. And so, I feel very fortunate. I have been humbled by the people that I have been able to train, learn, and work with. And I'm currently at an institution where the value of diversity, equity, and inclusion is never understated. And I will say that when I was a fellow, a cardiac surgery fellow at MGH, prior to my graduation, there had only been one other woman who had declared cardiac surgery as a path that had graduated from the program. And I graduated in 2018, so that wasn't all that long ago. And there was only one other female cardiac surgeon that preceded me. And to say, and that, which I think kind of brings this all kind of full circle, that person was Dr. Jen Walker, who took me on my first organ recovery. And so the importance of seeing people like yourself, mentorship, sponsorship, really, really cannot be understated. Right now at UCSF, we are a program that has currently, we have 2 women fellows, and I think that's awesome. I mean, we have 2 women, both who are going into cardiac surgery, and it's a pleasure to work alongside them, train them, and watch their careers grow each and every day. And I will say, I'm proud to say that the one who's a little more junior is going into thoracic transplantation. And so that's a big win. Here we also have the director of lung transplant at UCSF is Dr. Jasleen Kukreja. She's a leader, a major leader in the lung transplant space. And so to have, 2 women transplant surgeons in the CT space, a couple of women trainees, and more in the pipeline is really great. And that all just goes to say, and that goes to show, that's why we were able to walk into an OR one day and just randomly have an all-women team that's doing transplant. It's a testament to the leadership of the institution, to the place, and to the community that we have established here.
You know, you've mentioned mentorship, and I'm wondering, in a field that's historically been dominated by men, how has being a leading cardiothoracic surgeon as a female influenced how you train or mentor the future generation of female surgeons?
Thanks, Mary. I think that's a really personal and important question. I feel a huge responsibility to help shape their careers. And I want to show them a positive experience, and I want to show them that it can be done. And I want to show them that it can be done in a way that is respectful, collaborative, and forward thinking. I think that's how you get the best out of people. I know that historically our profession has not necessarily been thought of like that, but it's changing. It's changed. And I feel very, very privileged and lucky to have the opportunity each and every day to come into work and hopefully, help inspire the trainees, the students, to go into what I do, because I love what I do. I think this is the greatest profession in the world. But also they teach me every day as well. I mean, like, I learn something new from those guys like every single day. And so it's not just a dogmatic, I'm teaching you what I learned. It's really a collaborative relationship, and one of the really, I think, best parts of being in academic medicine.
Absolutely. That's wonderful. And I think it absolutely is so important to have that representation. I mean, it's always important to us as we're working on publications and analyses that to get that representation. Mary, you were just looking at our representation even in the study, because not only in the practice of cardiothoracic surgery, but even in the studies of transplantation. Historically, RCT medical studies are heavily male patient dominated.
That's fairly consistent across cardiac research in general. Whenever you see these studies published, whether it's transplant or even interventional cardiology surgery, they're always predominantly men in terms of the patients. But we know that there are a lot of female advanced heart failure patients out there. And we really do need to pay more attention and to see more representation. And I'm wondering about your thoughts on that, Dr. Fiedler. Why do you think that might happen, where even though there are a lot of female advanced heart failure patients, why do you think we have more male patients represented in our studies and our publications?
Another great question. To be honest, I'm going to admit my own ignorance. I didn't even know that to be true until about 2 months ago, when I was asked to write a commentary on a manuscript that just recently, I think a week or two, came out in SIO about worse outcomes with respect to right ventricular failure after LVAD implant in women as compared to men. And so I read their study, and then I started looking into this, and I was shocked, just what you say. So what I found when I was writing this commentary was that women are wildly underrepresented in the clinical trials. Something to a magnitude of less than 20% of the patient population is women in heart failure and transplantation studies, despite women suffering from heart failure. And we know that they're undergoing advanced therapies, MCS, transplant, et cetera. And, the question is why? I don't really know why. Is it a socioeconomic factor? Does it have to do with, again, this question of female patient, male physician? Are they not being enrolled? Are they not being approached for studies? Are they at different centers, more community type centers that may not be enrolling in the trials as compared to academic centers? I don't know. But, and I don't have a great answer for it, but what I can say is that this is a critical question that needs to be addressed. And it needs to be addressed because we see in other aspects of medicine, there are huge discordant outcomes in terms of gender. And when we're basing therapies on results of clinical trials and studies that are entirely one gender dominated, it doesn't make sense for the other population.
Right.
And so I think that this is, and what I used this editorial commentary as, I think my conclusion was, this was a call to action, that we as a community need to think about this. And this is important. And the fact that the researchers who put out the paper demonstrated that there's worse rate heart failure in women, and we don't have a great understanding or reason why, should show us that we need to pay a little bit more attention to this. And specifically in the heart failure MCS transplantation space.
Absolutely. I think one of the challenges that sometimes I notice in the papers is, especially on a lot of the pivotal RCTs, prospective RCTs, they're limited in scale to 200 or 300 patients, and then when you only have 20% female representation, that's a few dozen patients that are being representing the entire therapy. And we were Mary and I were having this conversation and looking at the Guardian Registry, which I believe is about 40% women. And then we have several hundred women recipients represented in the study already. And I think we were having this discussion about the tool of registries to collect large data sets in order to represent different populations more holistically.
Yeah, exactly. Because that is one of the advantages of a registry is you're not going in with these strict bumpers of a randomized trial where you have strict inclusion and exclusion criteria. We're able to look at the patients that you see every day. They're all not perfect to fit into this little round hole that we set up in randomized trials. Randomized trials are fabulous and they're phenomenal, and they give us a lot of really great information. But also I think the beauty of having a registry where we can have these all-comers and we can look at things, for example, any kind of gender disparities in outcomes, as well as other subgroups that may not be as evident in the other trials. And the congenital cohort, we were talking earlier, you said you had a congenital transplant going on right now, or a congenital etiology patient. Those aren't always the subject of a trial and often are excluded. So I think this is one of the advantages. I'm not sure if you had any further thoughts on the use of registry data to understand outcomes.
I think it's incredibly powerful, as you describe. I think randomized controlled trials, this is the gold standard, but the registry data, if done correctly, with a keen eye to being very honest in terms of what you're looking at and the statistics, can be exceptionally powerful. And this will be the way that we can be very versatile and agile in terms of moving innovation forward and using this type of data as compared to waiting to the results of a randomized controlled trial. So I find the registry data, when done properly and analyzed correctly, to be incredibly powerful, important, and frankly, practice changing depending upon the results.
I'd like to shift gears a little bit, and I understand, aside from your work at UCSF, which is an extremely busy program, so I don't know how you have extra time, you're also involved with Team Heart, a nonprofit organization dedicated to improving access to care in Rwanda. Could you tell me how you got involved and a little bit more about this organization?
Sure. Team Heart, another thing that's very near and dear to me. So Team Heart, for those who are listening and don't know, is a nonprofit organization that's dedicated to improving and saving lives for Rwandans suffering from rheumatic heart disease. And Team Heart was started by Dr. Chip Bowman and his wife, Sia Patton Bowman, in Boston, Massachusetts, at this point almost, I think, 15 plus years ago, after really just an ask from the Ministry of Health of Rwanda to help young people suffering from rheumatic heart disease. Now, what's really exceptional about Team Heart is that the organization started in Boston, but has become really a nationwide, worldwide organization with volunteers and participants from all over the place. And so what began as a program where once a year, a huge group of people, it was like we fell down from the sky, doctors, nurses, perfusionists, we would land in Rwanda, we would operate nonstop for about a week. And then we did have, practices and procedures to work with our Rwandan colleagues to take care of the patients afterwards. We would go home and then we would come back and do this yearly. Now, what we recognized was mission trips are great, but sustainability is better. And so Team Heart, as we gained our footprint in Rwanda, developed really key relationships with surgeons, government, really the whole community and the whole country, rather, in order to try to create and work together collaboratively to create sustainable cardiac surgery in Rwanda by Rwandans for Rwandans. And so I would say I'm incredibly proud to have been a part of this organization now for 10 plus years. And we've trained now a handful of Rwandan surgeons, one who is back in country practicing cardiac surgery. He's the first Rwandan cardiac surgeon, with a team of Rwandan nurses, perfusionists, operating room nurses, ICU providers, who provide high level cardiac care for complex adult patients who undergo at this point, valve replacement for rheumatic heart disease. So that's what Team Heart is. I currently am on the board of directors as well as the surgical director. And I'm proud to say that we're going back now. I guess it's already June. We'll be there in October for another trip to Rwanda, working on mentoring and collaborating with our Rwandan colleagues.
So is that the goal for your next journey, is focusing on mentorship, or do you have other goals for that next?
Yeah, it's a lot of times, it's most of it, at least surgically, is focused on mentorship. So we want to be sure that, increasing complex patients, they can, the team is independent. They can function independently without us. What we can provide at this point is some additional help. If you've got a really challenging case and you want another set of hands or another set of eyes with a really great cardiac anesthesiologist and some high level ICU support, that's kind of, what we're looking for. And so we work together with the team on the ground to line up cases that we think are most appropriate for when we visit. And that doesn't mean that I'm doing the surgery. Most of the time I'm standing on the assistant side of the table, in the first or second assistant slot, just kind of helping out, giving some tips, tricks, and working with our Rwandan partners to get things moving.
How can other medical professionals who may be listening today get involved with Team Heart?
Send an email. We're always looking for good people. So check out the website, send an email. There's a lot of different ways to be involved in Team Heart or even other organizations who provide humanitarian medical care to countries throughout the world. But we're always looking not just for people to travel to Rwanda, but to help us with some of our education. Now in the era of Zoom, I mean, we have recognized how impactful it can be just to get people on camera over Zoom, and we can talk through a lot of education, go through simulation, et cetera. So we've got a lot of folks who are involved in things like that. So there's a lot of different ways to get involved. And if people are interested in getting involved with Team Heart, just reach out and I'm sure that we can find a place for you.
That is such an amazing organization. That sounds fantastic. And we'll add it into the show notes. So anyone who's watching or listening, you will have links at the bottom that you can click on to learn more about Team Heart. So thank you for everything you do to make transplant in UCSF possible, but also to improve cardiac care around the world. That's truly incredible. I guess looking forward for you in terms of the field of heart transplantation and cardiac care, what's on the forefront for you in terms of exciting changes in the field, whether technology or policy or technique? How do you see some of the exciting things that are going to be unfolding in the next few years?
Great question. I think it's hard to even know because it's been changing so rapidly already, right? I'm actually preparing a talk right now, and I've been thinking a lot about this exact question. And it's impossible to predict. I mean, I've been, machine perfusion came alive over the past 5 years. It's the hot topic at ISHLT. That will only grow and expand. Sherpa Pack, pushing the envelopes for cold ischemic time. Amazing. And I mean, how far can we go? What else can we do? Is it just the environment of the Sherpa Pack? Can we add something to the Sherpa Pack that might be able to improve the organs? Is there some tailored therapies based upon the donor and the recipient match that you can do kind of tailored drug administration or storage? There's all these different things that I think about that are possibilities, but we haven't even touched upon yet. So that's one aspect. I think another really important key thing that we need to start thinking more about, and we're looking into from a basic science kind of translational research standpoint, is in the DCD community and DCD hearts. Right now, our assessment of these organs, the functional assessment of them, is pretty rudimentary, right? If we're doing NRP, We're visually looking at the organ. We may or may not drop a TEE probe or float a swan during the recovery. But a lot of times it's just surgeon gestalt for an NRP recovery, recover the organ, put it on the Sherpa pack, and keep your fingers crossed that it's going to perform well. And we've been very lucky that they have. And same with the device, with the functional assessment of the device on machine perfusion. I mean, really, we're just looking at it visually and we're measuring lactates. I mean, we got to do better. And I think as we do better with functional assessment of these organs, we'll be able to take and recover more of these organs and successfully transplant them. So those are just some aspects, at least within the field of transplantation, that I think are going to be really important in the next kind of 1 to 5 years. And then holistically, the transplant community, our patients are getting more complex, right? I mean, the three of us have had this discussion. The recipients are challenging. VAD explants are challenging. Complex congenitals are challenging. And the impact of some of the innovative disruptive technologies that we already see in practice, such as the Sherpa pack, have been working. I mean, that paper in circulation that shows a low rate of PGD, even with long geographic times for LVAD explant patients and donor hearts recovered on the Sherpa pack, is really practice changing and important. And as we start managing and dealing and continue to have to manage and deal with this complicated recipient pool, it's going to be fundamental that we think through how we can bring in some of this innovative disruptive technology to the advantage of the sickest recipients.
You know, you mentioned the holistic aspect of the transplant field. And I know you've thought a lot about like the psychosocial implications of transplant in the recipient population. I'm wondering if you could maybe expand a little bit on that.
Yeah, I mean, can you imagine? I mean, I can't imagine going through a heart transplant. I mean, can you? It's life changing. I mean, it's life altering. It's life changing. It's life saving. I mean, our patients go through so much, and I think one of the things that I really personally love about being a part of the transplant team is I think that heart failure and transplantation is the original heart team, right? For all aspects of cardiac surgery, we now focus on multidisciplinary teams, and that has been demonstrated to improve patient care. We started this as a transplant and heart failure space. And one of the most important aspects of the evaluation of recipients for transplantation, truly, I believe, is the social work and the psychiatric evaluation, and then the support system and the environment that these patients enter in after. And some of that is very personalized, and other aspects of that can be truly impacted by the way that you set up your program. And so having support groups for our recipients afterwards, having people be in touch before the transplant with others who have gone through the same process, having, the transplant coordinators. And one of the things that I really like to do is see the patients as a surgeon, not just at the 2-week post-discharge, let me check your incision and send you on your way. But I schedule every patient that I transplanted to see me again at their 1-year transplant mark. And I think that's really cool because the patients have a relationship with the surgeon has a relationship with the patient. And sometimes you see these patients who are, go from being on ECMO in the hospital to looking quite, still weak and deconditioned when you see them postoperatively. And 1 year later, you really recognize the impact that you have made by the gift of giving someone a heart transplant. And I think that's incredibly important to maintain perspective when we doing what we're doing.
Hearing you talk about that, of course, the scientist in me is thinking, wow, maybe we could study that, because you are, as the medical director of quality and safety, quality of life, we know can significantly impact patient outcomes. We've seen that in many aspects of medicine. And it would be really interesting to quantify that and to look at the connection that's maintained between the team and the surgical team in particular, if that can actually influence the longer term outcomes. I think that's a great point. And, we've had conversations. There's been many a conversation at national meetings. I know Dr. Shaw at Vanderbilt, we've talked about this, the 30-day, 1 year survival is a crude and I think
old metric that we're using to document success in this phase of transplantation. Just because we can get a patient through to 1 year doesn't mean that we've done them any favors if we can't get them back on their feet doing the things that they love to do, living their life. And so I think that quality of life after these interventions is incredibly important, and supporting our patients and frankly our care teams through the transplant process is really, really, I think, critical.
Absolutely. I can't thank you enough for what you do in this field to help so many patients. And it's truly inspiring as our teams here develop new technologies and try to help push the field forward. Having partners like you to work with and really understand the impact that this is going to have on patients is so critical. The whole team here, as they're developing and looking at these new technologies, new innovations, adding therapeutics and adding new capabilities to technologies. At the end of the day, it's all about driving for that patient care. And you're absolutely right. Survival is an important metric, but by no means the only metric we should be using for success of transplantation. I do want to ask you before we go, are there any major events or initiatives you'd like to highlight about before we close?
Sure. Thank you. I think there's two. We had talked about this. The one I'm going to really plug is we are having the inaugural Women in Thoracic Surgery standalone conference this year, the beginning of September 5th and 6th in San Diego, California. As a long-time member of Women in Thoracic Surgery, I think, and as a member of the executive committee, I think that this is really important, and it demonstrates that we as a community of women in cardiothoracic surgery have finally reached that critical mass, where we have enough firepower, person power to get a standalone meeting. And so we're really, really excited about that meeting. There's some great speakers, so I would encourage everyone to attend if they're able to do so. And then from a transplant and mechanical circulatory support perspective, there's a great AATS meeting September 20th through 21st in Toronto, Mechanical Circulatory Support Thoracic Transplant Summit, that will also be, I'm sure, exceptional, just to talk about the latest technologies, the latest surgical practices and procedures. And I'm sure that that'll be an exciting meeting to attend. And I plan on being there with some of my trainees who are also enthusiastic about transplantation.
Well, thank you, and I appreciate you highlighting the women transplant meeting. That's very exciting. Congratulations on the first inaugural in-person meeting.
Thank you.
And thank you for making time today for this conversation. I've really enjoyed it. Love spending time with you. And again, thank you for everything that you do at UCSF.
Thanks, everyone. It was great to talk today.